good morning. I think, dear professor, and also doctor from some universities. I think I would like to offer my warmest welcome to all of you for that you have opportunity that we can discuss the first AAHCI Southeast Asia Regional Roundtable via Zoom meeting. So and also Habibah Usmani join us as well. So this is midnight with you,
Yes.
yeah? Time. Okay,
Yes.
Thank you very much.
Of course.
Yes, I think, yeah, there are some universities here from from NUS, and from Duknus, and from Gajah Mada, and also from Erlangga. First of all, I think we need to introduce yourself first before we continue to talk about our topics. First of all, maybe Habibah first from the headquarters, please.
Yes. So some familiar faces I'm seeing. Good to see you virtually. I remember meeting some of you at the Jakarta meeting in 2019, which now feels like forever ago. So thank you and welcome in joining us for this first Southeast Asia AAHCI Regional Roundtable. I am program coordinator, as some of you know, for AAHCI, the headquarter office based in Washington, D.C. And I'd like to just say that this is a very valuable time for our members to engage like this with one another so that we can derive on what best practices and lessons learned as we face the current pandemic and how we can share that within our network. So thank you for your time, and I'm looking forward to hearing everyone's perspective today.
Okay, so maybe Indah, our secretary from regional office, please.
Hello, my name is Indah. I'm the regional manager of the AAHCI SEA region, and nice to meet you all. Thank you for joining this Zoom meeting.
Okay, next for Adibah.
Good morning, everyone, and hi, Habibah. It's late for you there. I'm from KL. We've got a public holiday today, so I'm calling from home.
Okay, next from Gajah Mada, please.
Hello, good morning, everyone. Nice to see you all, and hope all of you are in best conditions.
This Prof. Ofa, yeah?
Yes,
Sorry,
I'm here. I'm here
Thank you.
with Dr. Maineni.
Okay, thank you, Prof. Ofa. And then please, Professor Koh from NUS.
Good morning, everyone, or more like happy noontime, everyone. I'm actually representing the Yonglin School of Medicine, and I bring greetings from our Dean, Professor Chong Yap Sing, who's unable to join us. But I'm joined by two members of our faculty. Professor Chung Hui Ju is the Vice Dean for Research, and he's in this webinar with us. And also Professor Paul Tambaya is a Senior Consultant in Infectious Disease, but also the President of the Singapore Society for Infectious Disease and Microbiology. So he's joining us as well. And also Ms. Crystal Hing is my assistant, and she's in this webinar as well. So pleased to meet all of you, for familiar faces, especially after the last meeting in Jakarta.
Okay, thank you. So I think next, Professor Wee Ju, please. Professor Ju.
Yes, good afternoon. Very nice to join colleagues from Southeast Asia on this webinar as well. I'm the Vice Dean of Research at the Yonglin School of Medicine, as Darun have already introduced. Hope to have a good discussion with all of you later.
Okay, thank you. Next, Professor Paul Tambia, please.
Hi, it's good to see some familiar faces, and thank you for inviting me to be part of this discussion. Over.
Okay, thank you. Next, Professor Teguh Ariandono, please.
Yes, I'm Teguh Ariandono from UGM. Yeah, I follow this. It's for this meeting. I follow this meeting. Thank you.
Okay, so we have from Duknus as well, right? Okay, so now from UI, we have Dr. Erlina, pulmonologist. Please, Dr. Erlina.
Hello, everyone. My name is Erlina Burhan. I'm from the Department of Pulmonology and Respiratory Medicine, Faculty of Medicine, University of Indonesia. Thank you.
Okay, so I think we have Dr. Kospiadi, is a hematologist. Please, Dr. Kospiadi.
Yes, good morning, Professor and dear colleagues. I'm Kospiadi Irawan. I'm the hematologist and medical oncologist from General National Hospital. Accompany Professor Ari to proceed with this discussion. Thank you very much for the invitation.
Okay, next I think Dr. Anis Karuniawati, our Vice Dean and also a microbiologist, and I will be chair this meeting this morning. Please, Dr. Anis.
Hello, nice to meet you all virtually. So I'm Anis. I'm the Vice Dean for Resources, Venture and General Administration and also Collaboration. And I'm clinical microbiologist and work also in the laboratory of microbiology, the one of the official lab for COVID-19. Thank you.
Okay, so before we start, I would just want to show you some picture here, please, about our conditions, our Asian countries. I think Indonesia and also Singapore still in the red area, and then for Malaysia, I think in the yellow. And we have still, like in Indonesia, we have still problems with the increased numbers of the cases, and also the case fatality rate is about 8%. So in this meeting, we hope so that we can get sharing information from other institutions about COVID-19. What is your most critical issue? I don't know, maybe from NUS, from and also maybe from Gajah Mada, Erlangga, maybe, and also from Jakarta as well. So we will talk about that issue. I think Professor Adiba and also we have Professor Tambia here, so who can share the informations not only about in Malaysia and also Singapore, but also maybe in the global about how to manage COVID-19. And hope so that we can, what is your most affordable lesson learned from these discussions? And maybe after that, Habibah can give a suggestion how that the regional office and also headquarters can support us during this time. Actually, I have give some questions before, and then we have got answer of this question. This is one, how that that the organization can help us in these conditions. And also we have Professor Chong Wan Cheng. So would you like to introduce me here? Sorry about that.
Hello, nice meeting everybody here. I'm Wan Cheng from Singapore, NUS Medical School, and happy to join all of you and learn from everybody.
Okay, thank you. Okay, so I think Dr. Anis can continue to chair this meeting, but I still follow about this discussion. Please, Dr. Anis, I think we can start from Indonesia first, and then we can see what's going on in other institutions. I think Dr. Anis will chair this meeting. Please, Dr. Anis, thank you very much.
Okay, thank you, Prof. Ari. So, as your advice that we will start from Indonesia, so please, I would like to invite Dr. Erlina Burhan, pulmonologist, to give us information about the condition of Indonesia and also all the difficulties that we face right now. Please, Dr. Erlina.
Thank you, Dr. Anis. I just want to give a brief information that the cases of confirmed COVID-19 in Indonesia is increasing day by day, even though from the first epicentrum in Jakarta is a bit declining, but as the whole, as a nationwide, is still increasing the additional number day by day. And but we are happy that the social limitation in a big scale is already implemented, and we do hope that this will give a good benefit of declining the cases. And one other thing that I would like to mention here, that we have a very huge problem in diagnosis. Saying diagnosis is in regard to the capacity of the PCR procedure. So that kind of a limitation is given impact to our decision making in managing the patient in the hospital. For instance, just to get the confirmed diagnosis, will take more than a week in many cases. Of course, there is a lab that can deliver the result in 1 or 2 days, but most of the lab, especially the central lab, I mean the government lab, their capacity is very limited. So the clinician is having problem in diagnosing this patient. So we got the result after 5 to 7 days. And not only in diagnosis, but also when we want to declare the patient is cured or not cured, because then there is again a problem. We did proceed with the swab and send to the PCR lab, but again we got the result after some days, many days. Then we could not declare the patient as cured, because we need to have 2 consecutive results negative after 24 hours of interval, and that is really a problem. And the other problem is the capacity of our isolation room, but that is again in line with the capacity of lab. If we can get the result real time result, then maybe we can manage our isolation room. So we not in the trap of keeping the patient in the isolation room while waiting for the result. But if we get the result timely, then we can move out the patient into non-isolation room and able to putting a new patient into isolation room. I think there is just the problem of the many hospital in Indonesia. And one in additional is also regarding the antiviral drug. There is also a limitation. We use here azithromycin combined with chloroquine, which those 2 drugs are not very difficult to find. But when it comes to the antiviral such as oseltamivir or favipiravir or Avigan, or even the combination of lopiravir plus ritonavir, then we have a problem because the availability of the drug is also very limited. Thank you, Dr. Anis. I hope that's give you a clear picture of the situation.
Yeah, so I want to add as a lab person regarding the diagnosis for PCR COVID-19. So the problem is that very limited laboratory that have the capacity to do the PCR lab, but now so at the first phase, the government appointed only some few laboratory which is belongs to or under instruction of Ministry of Health, and also some are laboratory from university. But now the government open for all, also the private laboratory and the private university to do this PCR method to help the diagnosis. But the main problem in our field is about the availability of the reagent. Both mostly are the RNA extraction reagent are very, very limited. And for PCR reagent itself, it is not really a problem, but we think that it is, so the availability is maybe only until 1 or 2 months, the next 1 or 2 months. So the problem is actually not the importation, but the production from the producer. But good that some or most of the reagent now come from China. So we hope that it will be continuously available now, but it is started now. Maybe this week will come some reagent from China, especially for the RNA extraction reagent. So please, so of course, we need advices from maybe from other country how to solve this problem, because for RNA extraction, for example, we used to use the in vitro gain from US and also the Kia gain from Germany, and we know that both are also needed in each country. So this is also the big problem. And also the, for example, expert, which can be diagnosed for less than 1 hour, it is also very, very limited. Even though we actually already have the machine, so around 900 machine is available in Indonesia, but we cannot use because of the reagent for the cartridge is not available. So thank you, and I proceed to maybe Dr. Kospiadi. Do you have any other comment for this?
Yeah.
Oh, the sound is not so good. Maybe.
Dr. Anis, I think I will follow later on because my field is in the experimental clinical.
I'm sorry, Dr. Kospiadi. The sound is not
clear
good.
enough. This is clear?
Now, yes. Maybe clear? You the video should be off to make it better.
Okay.
Yes.
This clear?
That's right. Yes. Thank you.
Okay. Thank you very much, Dr. Anis and Professor Ari, to inviting me to join this discussion. Maybe Professor Ari invited me to join this discussion regarding the plan to proceed with the clinical experimental trial for using the stem cell, mesenchymal stem cell, as well as the plasma convalescence that already approved by the ethical committee of the faculty and the University of Medical Indonesia. So we know that Dr. Erlina already mentioned the increasing of the case in the national level, right? But comparing to the other mortality rate in the severe and the critical level of this COVID patient, we know that 30 to 40% of the patient with no symptoms, and another 40 to 45% is mild to moderate, and 10% fall to the severe, and 5% to the critical level. So our team at this moment still screening the donor of the plasma convalescent, as well the preparing the recipient to receive the stem cell in the severe critical patient that using the ventilation, the mechanical ventilator. So we hope in the very short time, maybe the next 2 or 3 months, we will have the results to know this safety and efficacy of this method in the top of the best clinical treatment that we already know, like Dr. Erlina mentioned. I think that's all, Dr. Anis. Thank you very much.
Okay, thank you, Dr. Cospiadi. So we move to Gajah Mada, Prof. Ova. Would you please give some comment?
Yeah, thank you very much, Professor Anis. Yeah, I think for Gajah Mada, from COVID-19, we learn, especially for coordination and communication, besides what you have already mentioned from Universitas Indonesia, that about the development of laboratory. That is also one of the, we have the capacity building, improving the capacity of the laboratory for detections of COVID-19. And in terms of the academic health system here, this situation urged us to have a close collaboration with not only the hospitals. Here, Dr. Rukmono is here, the director of the main teaching hospital, but also with the provincial government, where the university is also part of the provincial task force that define all the strategy that should be taken by the province as well. And one of the problems that's already also mentioned before is about the capacity of the laboratory. For us, the sampling is still a problem. So number of sample is still a problem. But we also have although now we already have innovations like for swab chamber, that's to increase the sampling, but still not very many. So perhaps this is a bit different from Jakarta. So now we expand not only receiving from the Jogja province, but also we expand to receive from Jawa Tengah. So every day we can process in average 300 samples. And from Jogja is not, I think about less than 70 samples a day. So we also open for other province. And during this COVID also, we have several innovations that is related with the COVID management. One is about the surveillance system that's now is already being done and incorporated with the provincial implementations. Yeah. So we also recruit the volunteers to also involve in the tracing and tracking the case. The other things is we also develop together with other university here with Gajah Mada together with Airlangga and also Mataram developing the IgM rapid test for COVID-19, and now is on the phase of finishing the trial product, and will be launched next on 20th of May by the Ministry of Research and Technology, and then after that we will have like the field testing. Yeah, about the screening or the diagnosing of the COVID in the field is still a problem. Like if we use the PCR only, it will take, I don't know, long times. And we need for the field, we need an acceptable and also like easy to use and easy for sampling and easy to interpret. Even like the sensitivity is compared to the PCR is not very good. But the new IgG rapid test that's being developed is assured to have a higher sensitivity because it uses the local antigen. And we're still waiting for that, and we really want to share with other countries about how you actually like define the zero prevalence survey, because this is also important for the policy in the not only in the provincial but also in the country level. So whether the strategy for limiting movement, like we have already done, so not totally isolation in Yogyakarta, is good enough and not have bad impact or for the socio-economic life of the people. So that is also one of the points that why we try to develop this rapid test. Yeah, not only the PCR. So we want now study the accuracy of the rapid test compared to the PCR, and also we will also piloting the rapid test in the community using different approach. So one is approach to a group of community, and the other is approach to the risk workplace, yeah, like for example hospitals or other health center or markets, yeah, something like that. Yeah. This is still under process. And the other thing we also develop, I think I already mentioned about the chamber for swab and also the personal protective equipment. Now our faculty of pharmacy also already prepared for testing the personal protective equipment. Yeah, locally, yeah, but it's already being certified as well. And we also still waiting for the ventilator for the ICU that now still in the process of producing the prototype. So we wait up to 10 prototype that should be clinically tested, yeah, in the field. So it's hopefully by the end of this month it is already done. Yeah, I think the other is about the knowledge sharing. Perhaps Dr. Heneni will share more about the knowledge sharing.
Okay, so it's one of our mission is to give to share our experience, also our knowledge not only to our member of academic system, but also from the more wide community. So we have two platforms. First is from the lay person from the community. So we have a multi transdisciplinary team. Media, so we gather and also develop and also make a dissemination of this information to the community, and we are very lucky because we already have in a head like a YouTube channel to give accurate and also update information related to the COVID. Because we know that recently there are many hoax, so we have to provide from the update and scientific information. And we also conduct a webinar, scientific webinar. It's not only from the clinical aspect. From the clinical aspect is led by our Cochrane team, but we also serve from the research management. For example, we do serial online course, weekly about hospital disaster plan. So the participant not only from the hospital, our member, but also via the hospital. Yeah.
Okay, we also have here Professor Teguh, Professor Budi Mulyono, and also Dr. Rumono. Would you add something? Dr. Rumono or?
Tapi kalau orang tua sudah berpola, tinggal mulai berapa persen, kalau ada yang dibutuhkan.
Dr. Rumono, are you here?
Yeah.
Yeah. Okay.
I follow the conversation and I agree with we already processed so far with our teamwork in the medical faculty and hospital, but also we have collaborating research, involving all faculty involving in a hospital and a medical faculty, not only in Sarsito, but in our hospital networking as well.
Okay, thank you.
Yeah, Prof.
So, Prof. Teguh, do you want to add something?
Yes.
Yes, please.
I think the dean and the director has explained a lot about our condition now. But in my my concern is about the education. Maybe the dean will explain also, because it changed a lot now. Education for undergraduate and also for the co-assistant and the trainee, and then maybe I want to know also from other center, from Jakarta, from Surabaya, or Singapore, how they can manage the education at the moment, because of the condition now is very different.
Yeah.
Thank you.
Yeah. Thank you, Prof. Teguh. In fact, that in Gajah Mada there are many adjustments for education, especially for the academic phase, because we don't do any big class and only online. I think this is already followed by the other university as well. But for clinical training is very limited, like for clerkship, is very limited, We also use online because the patient is now reduced, and so we mainly have for the discussion or tutorial, and we plan to have deficiency weeks or deficiency periods after the COVID condition is diminished, But we also have many innovation for education that is related with the community service, which we use the community and family healthcare interprofessional education, where they work together and they're partnering with the families and building up the health literations of the family. And with these activities, the students also get many skills and also many knowledge for that, and learn what information that they have to cover for COVID-19. But the families also have benefit for this kind of education. So this is some innovation, some of the innovation that we look for during this COVID. I think there are many more. Yeah. Professor Ari, I think just 2 weeks or 3 weeks, we also have a special webinar discussions about education. Thank you.
Yeah. Thank you. So I think this is a very big concern as well, education during the pandemic, and I think it will be very useful if so colleges from KL and also from Singapore and others can share the experience for the especially for the clinical practices. So next we
Dr. Anis, I think
yes.
I want to, we have we agree that for today's discussion we just talk about the most critical issue, and I think we can maybe, because we only have 1 hour, maybe for the next meeting we focus about the education, how to manage the education in this COVID. So that's why we just to talk about the most critical issue first, because we are clinician here, need the information, sharing information that we implement to our patients. So we have Professor Charlotte from University of Philippines here as well.
Hello, Professor Charlotte.
Hello. Yes. Thank you for inviting us. I'm really very happy to be able to join this meeting. COVID has really challenged the UP College of Medicine very much. I did send out a report, and we hope to be able to update this.
Okay. Yeah. Dr. Anis, I think we have Dr. Andi Hermansa from Erlangga. So
for Erlangga, yeah.
Yes, so please continue, Dr. Anis.
Thank you.
Okay.
Yeah, please, Dr. Andi Hermansyah, give some
Thank you
comments for this. Yeah.
Thank you very much. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Hello, everybody. I'm representing the academic health system in Universitas Erlangga. Based on our discussions today, I would like to report some of the things that might be interesting for all of you and also might be important for all our stakeholders in the Southeast Asia particularly. So in a sense, there are 3 measures that we have done to at least tackle this issue about COVID. The first thing is about the prevention, second about the promotion and identification, and the last thing is about the treatment itself. So when we talk about the prevention, we often become, a lot of estimations about when the COVID will be ended, when it's the time the period will be over, when the curve will be flattened. In Indonesia, there are 3 models that have been applied at this moment from the University of Indonesia, from Gajah Mada, and also from Erlangga. Depending on the scenario, depending on the mechanisms, all of them are thinking about at the latest might be a June, August, or September sort of things that this pandemic will be over. However, what is important at this moment is, including in the province of East Java and also within the neighborhood of Universitas Erlangga, is that the implementation of social distancing in a large scale, or we so-called the PSBB, the large-scale social distancing, have been applied, and then it is really crucial to limit and also to help flattening the curve. Apart from the PSBB or the social distancing, we also, in collaborations with other stakeholders, to provide supplementation or nutrition for, particularly for not only for the healthcare providers, but also for the targeted social groups and also the targeted communities that quite fragile for the attack of COVID. And the prevention is also part of the issues in terms of the quarantine process. At this moment, our epidemiologists also think about how to maximize and how to ensure that the quarantine process really conducted cautiously and also effectively. Because as a matter of fact, although people are quarantined, they are still be able to approach their relatives, and also they are get socialized each time. So it's a big problems for many stakeholders as well. In terms of promotion and identifications, I do agree with the previous comments about the surveillance systems and the tracing systems. Thanks to UGM, thanks to Unit Mataram, and we have a team that produce a rapid test together, and then it is very crucial because for my background is pharmacist, and we've done and also we receive a number of reports about the current rapid test that is imported from the abroad, particularly from the mainland China, that the quality have been jeopardized by the number of wrong samples and wrong calculations, wrong results, so false results. So it is part of the problem. So the rapid test, our rapid test perhaps can be an alternative to the existing rapid test devices. In terms of promotion as well, the process of educating the society is also ongoing very good. Although there are some resistance, of course, there are in fact increasing resistance in terms of culturals and also economic factors due to the fact that the life is already limited, the economics is already shrunk, and also many issues related to the quality of life and quality of scale of economies as the impact of the COVID. So it is a big problem. It is a bit of a problems in terms of how to promote and people to stay safe during the COVID. In terms of the treatment, the previous speakers has already mentioned great deal issues about how to treat people with coronavirus, and also how to do treatment during this pandemic crisis. We do have collaborations with the Institute Technology of Surabaya, 10 November Surabaya, and in building a robot called Raisa. It's a robot that take care the treatment to ward, so it's deliver drugs, deliver what is called food into the ward of the COVID patients. So it reduces the interactions between it limits the interaction between the health workers, particularly the nurse and the doctors, with the as possible as it can be with the patients. So it's a help a lot, and during the quality is there, but the interactions can be managed in the minimum scale. We also there is a hope for the genomic mapping that is currently conducted, that we have already identified six genomes of the coronavirus, and it's gonna be, it may be improved, it may be also increased in terms of numbers. However, this might be showing or highlighting the type of coronavirus that is spreading in Indonesia. And also there's accelerations for investigational new drugs. So at this moment, there are 6 candidates of drugs are being tested for almost all to become in preclinical trials. Uh, these drugs, this candidate of drugs might be come into the market at the soonest, probably the end of 2021. However, it is still a shrimp, what is called a shrimp of glory, a light in the a lightest light that we can have provide for the what call for reducing the pandemic. In terms of barrier, of course, there's a lot of barriers that is occurring at this moment, including for the such as limited supply of reagents, limited supply of vaccines, and also shortage of health workers and shortage of facilities, including the ICU. Um, for examples, we have broadened our ICU and also added some facilities, including opening a new wings in our hospitals. However, we also in bit of burden in case of uh, receiving the explosion of patients, either undetected or the positive one. So it's a bit of problems. The good things about whole the things is there are so many facilitators, there are so many supports from the stakeholders, including the accelerated process for the drugs registrations and also drug trials. And also the policy of work from home is indeed a very important to limit the mobility of the peoples. And again, the collaborative works, particularly with the provincials and also the national level, is conducted harmoniously. So it's a good signs for the improvement. Uh, Within the past 1.5 months, I also coordinated with our colleagues, particularly from Brunei, from Malaysia, and also from the Australia, and it shows that the number of other countries is reduced, is already minimizing. However, it is still part of our attention that there will be a second or third wave of infections, in which this may take in a number of places, such as in Brunei and also in Malaysia, particularly after the social distancing or the limited distancing will be relaxed in the end of May this year. So it's a bit of issue. So I do hope this can be a reference for all of you. Thank you very much. I give it again to
Anis, I believe you're muted right now. I believe you're muted.
Yeah, sorry. Thank you, Professor Habibah. Thank you, Dr. Andi Hermansyah. And now we move to Professor Adiba. Please, we limited the discussion about the clinical issues. Please give us some comment for all the explanation from Indonesian, and also maybe you have some also news from your country as well. Thank you.
Thank you very much, Dr. Anis. Assalamualaikum, and very sobering to hear of all the efforts in Indonesia. Just before I speak about our experience here, I didn't get a sense of the availability of PPE in parts of Indonesia, because that was one of the critical, and still is the critical factor in our hospitals in Malaysia. So it'd be nice to hear later on the issues around supply of PPE in your hospitals. We heard a lot and sympathize with the problems around diagnostics and testing. But I didn't quite get a sense of how things are like with PPE. Having said that, I think very briefly in Malaysia, the government put in control measures very early on in January. And although I think on the whole we have things under control, with new infections in the double digit being reported each day. We have big challenges, especially within vulnerable populations like documented and undocumented migrant workers, and refugees, and also people in places of detention, including prisons. So those are the areas that I think we need to put more focus on nationally. And also, as we open up from the lockdown, there is a lot of confusion within the industry on how to manage this safely. including in healthcare facilities, because up until now, most of the management of COVID-19 patients are in the public sector, in the Ministry of Health hospitals, as well as the teaching hospitals under Ministry of Higher Education. So I think the general practitioners in the private sector and in private facilities are also struggling with how to manage COVID moving forward, because patients are not going to come to you saying I have COVID-19. So segregating and ensuring compliance to infection control, early diagnosis of patients and isolating them is going to be a challenge if hospitals are not prepared. Especially patients who may come with another illness, but are also harboring COVID-19. So those are the things that I think at this point in time we in Malaysia are grappling with as we ease off the lockdown and get different sectors of the society prepared, including the healthcare sector that up until now have not been directly involved. More towards the clinical experience in my own hospital, I think we put in a lot of effort in ensuring patient safety and healthcare worker safety, because ours is a very large hospital that I guess can be described as a hybrid hospital. Hospital Sungai Buloh was designated as a COVID hospital and basically decanted non-COVID patients to other hospitals, but we didn't have the luxury to do that. But what we did was kind of move patients into other parts of the hospital and designated an area as a COVID hospital. We have enough, or up until now, we have enough isolation rooms, although not all are negatively pressured. But I think with all of that, we managed to hopefully minimize intra-hospital transmission. The biggest challenge and nightmare, I think, we don't want what we see happening in other parts of the world with large community prevalence to happen to our hospital and have healthcare workers getting infected as well. We didn't, thus far, we've not managed that many patients. We've managed slightly over 100 patients since the epidemic. In Malaysia, every single COVID positive patient is admitted to an acute care hospital, whether they are, whether they're symptomatic or mildly symptomatic, or patients belonging to the at-risk category. So for the most part, I would say 80% of our patients were well and really needed very minimal care. We had a subset of patients who developed or either presented very, very ill with respiratory failure or progressed to respiratory failure under our care. Developing the cytokine storm phenomena. And in those patients, they were identified by clinical symptoms of increasing breathlessness, decreasing oxygen saturation, increasing tachycardia, worsening chest X-ray. And what was very helpful, I think, was also their biomarkers, especially CRP, ferritin levels, and of course you all also hear about the hypercoagulability with very high D-dimers, etc. In our patients, initially we followed, sort of international guidelines and used hydroxychloroquine, azithromycin, and then Kaletra and interferon. But many of our patients didn't tolerate the Kaletra. They had worsening liver function tests with it. So we actually stopped using Kaletra very, very early, particularly when results of the study studies on Clitra were not very favorable. We also elected not to use a combination of azithromycin and hydroxychloroquine because of the concern for prolongation of QT interval. So what we do now is basically hydroxychloroquine alone for patients with moderate symptoms, or and especially if they have risk factors such as age, BMI of more than 30, hypertension, diabetes, the established risk factors for progressive and complicated disease, including cytokine storm. We should be ready to, and we are ready to, so we used tocilizumab in 8 patients, 2 of whom were already intubated by the time we used it, and 1 has since recovered. 1 patient unfortunately passed away. In the others, they didn't progress to needing mechanical ventilation. We've also been very sparing about the use of early intubation. We've basically been using high flow nasal cannula for those who desaturate and proning them. So very few of our patients, as I said, we've had very few, slightly over 100 patients, but not many of our patients ended up being intubated. So lastly, given the favorable outcomes in those few patients that we've treated with tocilizumab, we are ready to embark on a tocilizumab versus methylprednisolone clinical trial, randomized clinical trial in patients with progressive disease due to the cytokine storm. So we hope to start recruiting soon together with colleagues at 3 other Ministry of Health hospitals. So that's it for me, because time is running short.
Yeah, thank you, Professor. Yeah.
Dr. Annie, sorry to interrupt, but as Professor Adiba mentioned, since time is running short, I just want to make sure our colleagues from NUS, Philippines, are able to stay on a little longer, just so we can get through this first question of what the most critical issue is. And just for everyone's knowledge, AAHCI will work with Universitas Indonesia to schedule a roundtable a bit more structured in the future, focusing on exactly what's on the top of your mind. So,
yep, yeah. I can stay on a bit longer.
Okay, great.
Thank you, Professor Tam. Yeah. Yeah, thank you, Professor Habibah. So we move to NUS. Who will give comment first? Or
so maybe
Professor
I'll ask Prof. Tambaya to start off, and maybe if there are things that Professor Chun Woo-Ju would like to jump into, he can go ahead after that. So Paul, can you maybe start off for our COVID-19 response? Yeah, thanks a lot.
Yeah, so I think, again, as you've already heard, the numbers in Singapore are rising, and that's primarily through outbreaks in the migrant worker dormitories. And I think Professor Adiba has already hinted that there are certain populations which sometimes are under the radar. She mentioned prisoners. Malaysia had the advantage of knowing that we had this problem with the migrant workers, and so they are also very conscious of issues with cases that are spreading very rapidly in migrant workers who are living in very close conditions. But what I think might be relevant to this group is to see what we are doing with this this cohort and across the country as well. As you have pointed out, with Invitrogen and Qiagen, it's very hard to get the reagents for extraction. And in the past, we used to test every patient every day until they get 2 negatives, and then we discharge them. But we've been forced to be a bit more selective. And like, for example, in the migrant worker dormitories, they are testing primarily those who are symptomatic. And the aim is to identify those who are ill so that they can triage them. Those who are very ill, go to hospital where they can be treated appropriately. And those who are moderately ill can go to a community isolation facility where they can be monitored. We have looked at various alternatives, including pooling and serological tests, but so far we are still very much dependent on the swab-based PCR assays. We've also looked at the expert system, and the limitation of that is the number that you can do at any one point in time. But the real game changer for us has been the use of the Roche Cobas, which is a very high throughput system. And that, again, although it's dependent on reagents, it has allowed us to do a large number of patients in a relatively short period of time. In terms of treatment, we've had a national guideline, but unfortunately, there's really no solid evidence backing anything. So some doctors still use Kaletra, some are using hydroxychloroquine. We've had our first patient who's received we've actually been exploring, the convalescent plasma option, and we are enrolled in the Gilead remdesivir trial, as well as in the NIH remdesivir versus placebo trial. So there's a lot. I'm happy to take any specific questions by email if the facilitators want to channel them. But again, I understand time is running out. I'll hand the time over to Viju. Over.
Yeah, thanks, Paul. I would just like to add a few things. I mean, as many have mentioned, one of the critical shortages are in terms of reagents, particularly RNA extraction reagents. So early on as well, a couple of our labs in Singapore has developed a direct PCR method where you do not need to apply RNA extraction before doing the PCR. And so that has helped to some extent, but there is a lot of active research funded by the government as well as the university to look for solutions into these issues. So we are actually developing assays and kits that are not PCR dependent to overcome this problem, but with the similar kind of sensitivity and specificity or even better. The other thing also is that we are facing issues potentially with shortages of transport media, swabs. So we are also developing our own swabs using 3D printing technology in the university. And in fact, today, the first trial of our own swab is going to be conducted by our ENT surgeons to ensure that there is similar collection accuracy as well as comfort to the patients. So the university actually has been very active in a number of these research in our critical areas. Also, Singapore is trying to ramp up its clinical testing to about 40,000 tests per day, and that requires tremendous amount of resources nationally. And so there's a national effort ongoing. Our contribution to that effort is really to get volunteer trained research staff that can do PCRs and assays like that. So we volunteer our manpower, and we also volunteer our equipment and reagents towards this national effort, because currently in the university, our research are all shut down with only less than 5% of research staff going back to the research lab focus on COVID-19 research. So one of the key challenges that the school have to face in the last few months is actually coordinating this shutdown in research, and while able to maintain our equipment and so on, and samples that are in liquid nitrogen in good conditions, as well as find ways to actually help our students, our graduate students, as well as our junior faculties that are requiring promotion and tenure, because all their research are affected during this time. And so that's another kind of challenge that we as a university have to face. So I think that's just to add on to Paul. I don't know whether, Paul, you want to mention a few words about this very exciting new project, that trial that we're starting in the dorm with 5,000 patients looking at different prophylactic treatment for them.
Yeah, this is still very early. This has been a major effort, and actually one of our neurologists is driving it. Because of this large-scale spread among the dormitories, we're looking at chemoprophylaxis. We did that during H1N1 with oseltamivir, and it was very successful. This time, there's no clear-cut drug, so we're studying various regimes. We're hoping to start next week, and we will definitely keep everybody posted on the outcomes. Over.
Thank you. So, is it enough, Professor Ko? We move forward to Professor Charlotte from the Philippines.
So I'd like to request Dr. Coralie to present for UP College of Medicine.
Yes, please,
Dr.
Coralie.
Yeah, I have some slides. Can I be asked permission to share screen?
Yes, please.
Yes,
please, yeah.
I will make you a co-host so
Okay.
that you can do so. Go ahead. You should be able to share your screen now.
Is it showing?
Yes.
Yeah.
Yeah, okay. I just have a few slides for our presentation from the UP College of Medicine. And Dr. Charlotte can add to this after the presentation. So one of our most critical issues when this began was the safety of our healthcare workers, staff, and students. This included the procurement of PPEs, ensuring safety in hospital and in campus, and providing housing in nearby hotels and dorms for our healthcare workers who couldn't go home. Okay? The Philippine General Hospital, which is our training hospital, is now a COVID referral center. So we had to renovate our wards, and duty teams were assigned to work in 1 week work shift teams. So 1 week goes on duty, and then after a week, they go off duty for 2 weeks. And of course, we had to look at our ventilators. We also looked at our dialysis machines, and we had to repair old ventilators. Our engineers and clinicians worked together for the development and production of ventilators and respirators. So this involved working with university faculty and researchers from another campus. So UP Manila is the health sciences campus. We worked with UP Diliman, where the College of Engineering was. And we established a hotline to streamline donations, patient referrals, and all inquiries. And well, you said, yeah, clinical, but anyway, one of our critical issues was the shift to online learning following the lockdown. We discovered that about 30% of our students have unstable or limited access to internet, and we've had to supply them load and for some laptops. And not all faculty are ready for online learning. I mean, a large number of faculty. And concern over the development of clinical skills due to lack of patient exposure is a problem. Of course, we realized that our health system was unprepared for this pandemic. There were at the start no existing plans in place should the pandemic occur. And at the start, we had the lack of validated testing kits, the lack of laboratories with required biosafety. We have improved in these parameters. So what have been our lessons learned? The Bayanihan spirit. The Bayanihan is probably, I'm not sure what the right terminology would be, but Bayanihan is something like a collective community spirit. So this Bayanihan in the Philippines has been overwhelmingly felt from both government and private sectors. And we also realized that the Filipinos are very resourceful and creative and innovative. So our National Institutes of Health have developed locally developed test kits using RT-PCR technology. We have CBOL, which is a surgical innovation unit, developed telepresence monitors for our PGH patients to allow the relatives to chat with patients via social media within the COVID ward. Of course, there have been efforts to develop and produce ventilators and respirators. We just have, I think, 1,500 respirators for the entire country. And we're also looking at convalescent plasma, plus a lot of other researches. So our guidelines evolve over time. And UP Manila provides guidance to our Department of Health. So our specialty societies have been reviewing publications to come up with evidence-based recommendations on diagnosis and treatment. So we have ethics guidelines for COVID that has been released and published. And our UP team of researchers is also participating in clinical trials for treatment, like the Solidarity and Remdesivir trials. And there are about 79 COVID researches ongoing. And we have utilized our MD PhD students to join these researches. So far, extended community quarantine seems to have helped. That's it. So, Charlotte, would you like to add anything?
Yeah, that's quite comprehensive already. But the amount of researches that's been replacing most of our traditional researches have been really astounding. And we're quite happy to say that the UP College of Medicine faculty have been very much involved as well with national efforts, being part of the task force of government to be able to mount a very good response to this COVID problem in the country.
Thank you. Thank you very much, Prof. Charlotte and Dr. Carol. And we back to Singapore, to Duke News and US. Dr. Cho, Professor
Hello.
Cho.
Yeah.
Sorry.
Yeah, good afternoon to all. I guess Paul and Viju has spoken quite a bit. We are, after all, in a very small country, and we share many of the same situation. But I thought if there's anything to add on, maybe is to address some of the concerns that our colleagues have mentioned earlier, like bed situation and all that. So, like Malaysia, initially, we admit every single infected patient to the acute hospital. But you would have heard early on when Paul mentioned that now with the large number of migrant workers, we have built other community isolation facilities for some of these people who are less ill to go into these facilities. But nonetheless, we make use of technology to make sure that their vital signs are monitored on a regular basis, and that is tapped into a national EMR system, so that if hopefully not anybody is ill and then has to be transferred to hospital, there will be continuity of records, and so that continuity of care is not affected. But even in the acute hospital setting, what we have changed is that, yes, we had the luxury of having isolation ward with negative pressure rooms and all that. But as the numbers increase, obviously those isolation rooms is not enough anymore. And so what we have done differently from what we initially started is that we put the unconfirmed cases, in other words, they admitted, we suspect a diagnosis, we are waiting for diagnosis to be confirmed. We put these people in a single isolation room because we don't want them to obviously mix with the others. Either they get infected from the ones who are positive, or they may infect other people. But once we have confirmed that they are positive, then actually all the confirmed positive cases are now in cohorted room, having the consolation that because they are all infected, then we are not putting anybody more at risk than other people. That is one way to tackle the capacity issue. We are lucky in that our ICU population is not so high. Part of the reason is because since currently our major problem is the migrant worker population, they are, thank goodness, relatively healthy people, but we are worried about the nursing home population, and so we are taking active measures to make sure this population is looked at very closely. At the start, we do have one or two of the healthcare workers who take care of the nursing home population who get sick, infected, probably from the community, and then as a result, probably infected some of the inmates in the nursing home. So since then, what the country has done is that we actually take priority to swab every single one of the healthcare worker in the nursing home, and if those healthcare workers turn out to be positive, obviously we will treat them accordingly. But those healthcare workers which are tested negative, then now these healthcare workers are made to stay on site in the nursing home, so that we know that these people are well, and they are kept in the nursing home to look after the nursing home population, which is obviously the vulnerable population, because for the mortality we have in Singapore, thank goodness so far not so high, but they are basically majority the elderly. So the nursing home population is one that we worried about, and to tackle it and to avoid this problem getting worse is really we take care of the healthcare workers who usually would have go home every day and come back to look after these population, that in the meantime they may get infected in the community and then affect this population. So now we have prioritize the swabbing of all these people, and if they're swab negative, they stay in the nursing home. So this is what we are doing. So I thought this might be something you want to share. Of course, we can talk about some of the therapeutic research efforts that we are doing, but they are really still early days. Like, for example, you all may know of Prof. Wang Linfa, who is looking from the investigation point of view, neutralizing antibody, which is more specific, and other immunotherapy, but they are really early days. So maybe hopefully in the future we have a chance to talk more about it. But really I thought about how to make use of limited facilities and how to avoid having more people getting infected. These are some of the measures we do to hope to make a difference. Thank you.
Yeah, thank you. So any one from the Duke and US want to add? So
I think I'm the only
Cho
one.
is the only one.
Yeah.
Okay, thank you. Sorry.
That's okay.
Yeah. Okay, so thank you very much. So, and everyone has already talked in this occasion, and I think in conclusion that some research are still ongoing in all aspects. So for the prevention, diagnostic, and also the treatment, and prevention activities is done in the community level and as well as in the hospital level. And I think the most important thing and the most critical thing that we have to solve together is about the diagnosis, that the limitation of the reagent. But I think this is also my question actually to Professor Tambia about the that to spare the reagent. Actually, we can test only the symptomatic patient, but then Professor Cho said that you also test all the health workers. So actually, WHO and also other international guideline doesn't mention any criteria for screening for healthcare. So who has to be screened? Because now everyone want to be screened actually.
Yeah, no, that is true. We have the same problem. A lot of my colleagues want to be screened, so I send them to the private hospital and ask them to pay $200 and get it done.
Oh, okay.
But we don't do that routinely. What one Professor Chow was talking about was those in nursing homes, because the nursing homes are especially vulnerable, and many of the healthcare workers working in nursing homes are living on site. So they are in very close proximity both to the patients, and we have seen what happened in Europe and in North America, where you have explosive outbreaks in nursing homes. So the screening for healthcare workers currently is only being done in the nursing homes. And again, it's an issue of reagents and things like that. For those outside of the nursing homes, the construction workers, the people like that, we are almost all of them are symptomatic when they get tested. Over.
Yeah, thank you. So,
Dr. Anis, maybe, Dr.
yes,
Anis,
please.
you can chime in terms of healthcare workers screening. Like Paul said, everybody wants to be screened every single day if they could. There is a lot of anxiety, understandably so. What we've put in at UMMC is a healthcare workers surveillance program. And it started off because at the very early stage of the pandemic, we had one healthcare worker who came to work not knowing that she was positive, and infected a few patients and other healthcare workers. And with that, we put in a surveillance in place where we, follow those who are managing known COVID patients, or in that situation I've just described, have come into contact unknowingly with someone who's positive, or there's been a breach of PPE. To date, we have had, I think, 1,600 healthcare workers on surveillance. We risk stratify them. We don't test all of them, obviously, and only test those who moderately, who are thought to have moderate or high risk. And with all that effort, we've seen very few intra-hospital transmission, thank goodness.
Yeah. Okay. So thank you. And
Can I just,
also,
sorry, I just want
yes,
to
Professor.
respond to Dr. Adiba. So, so actually, exactly like what Paul has added, the testing of the healthcare workers is really for those who have got contact with vulnerable population. And the truth is, testing them negative one day doesn't mean anything because they continue to have contact with patients all the
Yeah,
time.
you're
But
right.
so actually, what I, on the other hand, at this point, I thought what we need to look at on top of patient is that actually the mental health and the emotional status of our healthcare workers, and which is not addressed actually by testing, but something that I think all of us need to look at, because we are so dependent on them, but their health, their mental health and the emotional state is so important. So I thought that is something that we should keep in mind as well.
Absolutely. Yeah, so we've been working with us psychiatric department and counselors, and offer the services to both patients and healthcare workers. Yeah.
Oh,
many have
thank
not
you.
taken up the offer, I must say.
Yes,
Although a
yes.
lot of people grumble and say
Yeah.
stay and do things that that there is underlying anxiety and fear, but even though these services are offered, many do not take it up.
Yeah. Thank you, Prof. Cho and Professor Adiba. So, and for treatment, so actually we all follow the international guideline, and although there are some also other innovation that is going on research. So I think I'll give it back to Professor Ari, Dean Ari.
Yes. Thank you very much. I think we have got the followable discussions and also sharing from all institutions here. So I think we can maybe prepare the webinar. Maybe we can invite some of you to talk more, because you know that we have still problems with the screening, and then how to treat patient, and then about the health worker as well. So lastly, maybe Habibah will give some note, because I think you and Indah will work together to make some note here and then share to others members here, and maybe you give report to our health quarter. Please, Habibah.
Yes, thank you, Dinari. Thank you, Dr. Anise. And thank you everyone for participating in this roundtable. I think it's safe to say that there's a lot more to talk about in terms of how each country, each institution is dealing with the pandemic, and what issues are really critical at this time. So on that note, this is really the purpose of the roundtable and what AAHCI is aiming to do by organizing such virtual meetings. So what we will do next is take note of all the topics that you've mentioned that are on top of your mind, and send a few emails to each of you to see your availability for participating either in a roundtable, which is a more intimate discussion such as this one, or a webinar that can even be streamed live, but with a bit more structure, and at which point we would even invite our members from the US and other regions to weigh in on these exact issues and what their experience, lessons learned, and best practices have been thus far. So I think this is exactly what the whole point of AHCI is right now in a time like this, to bridge our network members together. So thank you again for participating, and Inda and I will be in touch for the next steps, and then we'll look forward to see you again virtually, as we all are used to saying now.
Waspada COVID di tengah bulan Ramadan.
Okay. Thank you, Abiba, and thank you all, and then see you again. And thank you for your time and your sharing to us. Thank you. Bye-bye.
Thank you, everyone.
Stay safe.
Bye. Thank you.
Bye.
Bye. Thank you.